Pleurisy is the inflammation of the pleura, the spaces that we were talking about where I used the bread wrapper and then the grocery bag analogy. Pleurisy often results as a complication of pneumonia or bronchitis. Signs and symptoms are abrupt pain is probably the most common one. Usually this pain is on one side of the chest or the other, so pleurisy is going to affect usually one lung or the other, not both. And the patient can usually point to the exact location of the pain. Breathing and coughing aggravate the pain. Diagnosis of pleurisy is, of course, the history and physical, what the patient says, how they describe their pain, as well as a chest x-ray. Treatment relies on treating the underlying disease as well as providing pain relief. So we're going to use analgesics. Here I have Tylenol, which we've had on every single slide, as well as Advil, which is an anti-inflammatory agent. Antitussives, such as cough syrup with codeine, can help somebody not cough so much if they have a dry, non-productive cough. Antibiotics, because this is a type of bacterial infection sometimes, and local heat therapy can also help. So that's why I have a heating pad. In extreme cases, we might have to have supplemental oxygen. We also, if the client doesn't do it automatically, teach them how to splint their chest when they cough, and that will reduce the pain of coughing quite a bit. Just like pleurisy is often a complication of pneumonia, sometimes a complication of pleurisy is the development of a pleural effusion. Again, that's fluid in between those two, the lining of the lung and then the lining of the chest cavity, those two pleura, the visceral pleura and parietal pleura. If the pleural effusion develops, the patient will experience progressive dyspnea, which is just shortness of breath, decreased or even absent sounds in the affected area. So you'll hear very diminished or no lung sounds on this side of the chest compared to this side of the chest, which might sound normal. And decreased chest wall movement on the affected side. So again, when you watch your patient breathe, you'll see this side of their chest rising and falling like normal and very little movement on this side. So it's that asymmetrical chest movement and asymmetrical breath sounds that really cues the nurse in on that something's going on this side, a pleural effusion or something like that, as compared to this side. Treatment of pleural effusion involves removing this fluid. If it's a small amount, maybe thoracentesis will be enough. Larger amount, we might have to use a chest tube. Chest trauma can result from either a non-penetrating or a penetrating injury. Non-penetrating or blunt injuries frequently result from a steering wheel in a car accident or a fall. Penetrating injuries can either result from a gunshot wound or a knife. Chest trauma can result in changes in the normal pressure relationships between air inside and outside the body and interfere with normal breathing patterns and disturbances in blood flow to the lungs. Signs and symptoms, well, this is the obvious sign and symptom. So obvious trauma to the chest wall. Less obvious signs and symptoms include chest pain, shortness of breath, cough, and then again that asymmetric chest wall movement where you can tell one side of the lungs is working fine and the other side not so much. Cyanosis, deviation of the trachea. Again, that's going to tell us that one of these things is not like the other. And then bloodshot or bulging eyes. Immediate care of a person with a chest injury is directed at stabilization and prevention of further injury. So that's why I have here, do not remove impaled objects. If we pull this knife out, we can create a blood gusher. So anytime someone's impaled, we're going to stabilize that with a bulky dressing, and that'll be more of a EMT activity rather than nursing. But if you work in an ER, you may see something like that. Remove clothing to assess the injury site and to observe for other injuries, such as bleeding. The more observant of you might notice that this dressing looks kind of weird. It looks like they forgot the last piece of tape, but actually that's done on purpose. Anytime we have an open chest wound, we want to cover it with an airtight dressing, but tape it only on 3 sides, and this creates what we call a vented dressing. And what a vented dressing allows is air to escape, but prevents additional air from entering the chest through the wound. If you were to completely seal an open chest wound, so put another piece of tape here where we have it sealed, air could continue to accumulate and cause a tension pneumothorax. So air could go in but not be able to come back out. We're going to monitor vital signs, level of consciousness, keeping in mind that the patient with this type of wound is at risk for shock. Remember, tape your dressing on 3 sides. I've also seen it done where they taped on 4 sides but left this little corner open. That's fine as long as it's open somewhere and creates what we call a vented dressing. Here's a picture, what I was talking about. This is just has the corner left open, and it's showing that when the patient inhales, the dressing prevents air from entering, but when they exhale, there's enough force that the air can escape. So this is a good diagram of how a vented dressing works. I mentioned a tension pneumothorax, and that's just one type of pneumothorax. I briefly touched on this earlier, that a pneumothorax is an accumulation of air in the pleural cavity. So again, between the visceral and the parietal pleura, we have an accumulation of air that puts pressure on the lung and then collapses the lung, not the other way around. So you can see that this lung is significantly collapsed compared to the other one. Pneumothorax is pretty common. Anytime someone has a chest injury, nearly half the people who have chest injury develop a pneumothorax. And there are 2 types. We already talked about the tension pneumothorax, but there's also one called an open pneumothorax. Just to recap, with a tension pneumothorax, air repeatedly enters the pleural space with inspiration, causing the pressure to rise, but because air is not escaping from the wound, the accumulating pressure causes the affected lung to collapse. What might result is that the heart, trachea, esophagus, and great blood vessels shift toward the unaffected side, and this is what we call a mediastinal shift, a condition that interferes with blood return to the heart. When this happens, as you can imagine, this is a medical emergency. The heart and aorta don't really like to be moved. Medical emergency because both the respiratory and the circulatory systems are affected. If not corrected, cardiac output will fall and the patient will die from this. So again, it pushes it away from the injured lung, because even though this lung is really small, it's the pleural space that's putting pressure and pushing the heart towards this area that doesn't have the pneumothorax. An open pneumothorax results from a chest wound that allows air to move in and out freely with inspiration and expiration. The lung on the affected side collapses. Again, the heart and trachea, esophagus, great blood vessels again may shift, but this time they're going to shift back and forth. And so instead of calling it a mediastinal shift, we call it a mediastinal flutter. And just like a mediastinal shift, it is potentially fatal. Signs and symptoms of a pneumothorax: dyspnea, tachypnea, which is an increased respiratory rate, if you didn't remember, tachycardia, so high heart rate, restlessness, pain, and anxiety, decreased or asymmetrical chest wall movement. Again, we're comparing the right side to the left side and looking for differences. And also diminished breath sounds on the injured side. So when you listen with your stethoscope, is it loud and clear over here and then you're not hearing much over here? So difference between the right and left sides are the key to diagnosing things like this. If the air can be heard and felt moving in and out of the wound, then we call it a sucking chest wound. And again, we're going to cover it with that vented dressing with the tape on 3 sides. Treatment of pneumothorax involves either a thoracentesis or a chest tube to remove that extra air from the pleural cavity. We might need to do surgery to repair the tear or the cause of the pneumothorax. We're going to monitor for respiratory distress, which includes monitoring ABG results. Watch for that tracheal deviation. So is the trachea midline or is it deviating to one side? We're going to monitor chest tube function, which we already talked about how we do that. Watch for titling to make sure the system is operating correctly. We want to avoid the side-lying position until the affected lung has re-expanded, because lying on the side can foster that mediastinal shift. Again, you have a bloated up visceral space on the one side, and it's going to want to force everything to shift to that unaffected side. Support and encourage coughing, deep breathing, and provide O2 as ordered. A hemothorax is much like a pneumothorax, except for instead of air accumulating here, blood accumulates in the pleural cavity, and we treat it a lot like we do in pneumothorax. The chest tube would just be placed lower and removing the blood instead of the air. Before we move on to rib fractures, let's take a quick pop quiz and see if you can remember everything that we've talked about. So the presence of air in the pleural cavity that causes the lung to collapse. Remember which one of these it is? Pneumothorax, presence of air. Collapsed part of the lung, specifically the little tiny alveoli. This frequently happens after any kind of surgery. When someone's been put to sleep, we call that atelectasis. And our treatment of that or prevention is turn, cough, deep breathe, and to use those incentive spirometers. Accumulation of blood in the pleural space. We're going to put the prefix heme on that, hemothorax. Just general difficulty breathing, we call dyspnea. And temporary cessation of breathing is apnea. And when somebody has sleep apnea, meaning they temporarily cease breathing during the night, they're often treated with either a CPAP or a BiPAP machine that does continuous positive airway pressure to prevent the airway from collapsing while they sleep. See if you can remember, this has to do with that mediastinal shift I was talking about. The nurse is assigned to care for a patient after a left pneumonectomy. Which position is contraindicated? So what position should they not be put in? And that is the lateral position. Again, we don't want things shifting over into that blank space that we leave due to the pneumonectomy. Rib fractures are the most common chest injury, and the most common cause is blunt injury from the impact of a steering wheel against the chest in a motor vehicle accident. Ribs 5 through 10 are most frequently fractured because they are the least protected by chest muscles. It takes approximately 6 weeks for rib fractures to heal, and those of you that have ever had those know that often the treatment is really nothing. We don't put a cast on, we just allow ribs to heal on their own. Signs and symptoms of rib fracture are pain, especially with inspiration at the site of injury, shallow breathing, holding the chest protectively to minimize painful chest movement. It's kind of like a reflex that someone can't help but do. There may or may not be visible bruising or swelling. Diagnosis is made by chest x-ray. Again, bones show up really well on chest x-rays. Medical treatment focuses on pain relief. We want the patient to be able to have good chest expansion and be able to cough if they need to, so we want to make sure that they have sufficient pain relief in order to do so, because shallow respirations, as we just talked about, can lead to atelectasis and or pneumonia. Analgesics, especially oral, are the most common things that are used. However, nerve blocks and local anesthesia may be used for some patients. Again, strapping the chest with tape and binders was once common practice, but it's not done very much now because, again, it discourages the expansion of chest wall and restricts breathing, so it's just allowed to heal on its own. Nursing interventions encourage use of incentive spirometry, and again, if it hurts too much to use the incentive spirometer, then we are going to give pain medicine so that it doesn't hurt too much to use the incentive spirometer. So we're going to encourage breathing exercises and instruct the patient to support the ribs while doing their breathing exercises and coughing. Flail chest is a little bit more serious problem that results from rib fractures that aren't just in one spot, but are in 2 or more spots that result in pieces of the rib like you see here just kind of floating around. When this happens, we don't allow the ribs to just grow together naturally because they won't. It requires surgical intervention, ORIF, like we've talked about in the past, where the ribs will be held together by some type of hardware. The main sign and symptom that distinguishes flail chest from other disorders of the respiratory tract is this paradoxical chest movement. And that's not talking about right compared to left. That means that this place where the flail segment is going to move opposite of the rest of the chest with inhalation and exhalation. Another problem that can develop if not corrected is, see these jagged pieces of bone? Those are just floating around, able to tear into the lungs or other organs and do no good. So this really needs to be corrected pretty quickly with surgery. One of the most feared things in nursing is when a patient develops a pulmonary embolus. And although this cute guy says breathlessness is the main sign and symptom, he's wrong. Here's a sample question. A client is at risk of developing a pulmonary embolism. The nurse monitors for which initial sign and symptom? Notice you don't see breathlessness, but instead it's going to be chest pain that occurs suddenly, and it would be accompanied by shortness of breath. The pathophys behind a pulmonary embolus is a thrombus that develops in the vein